all. This is Dr. Mobeen Sayyed from Drbeen.com. Welcome to one more show. So you have seen rock stars like Dr. Paul Marik, Dr. Corey, Dr. Tess Lawrie, Hector Carvalho, Dr. Eric Schultz, Dr. Hector Carvalho, and so on. We have one more rock star with us today, medical rock star. And not only he is a founding member of FLCCC and the protocols there, when I would show you his bio in itself is a study for me. I had to highlight areas to discuss. He has diseases named after him as well. So there are syndromes that are named after him. That is the extent and extensive work that he has done. So Dr. Joseph Varun, welcome. Thank you very much for being with us.
Thank you for having me.
So Joseph, what I'm going to do is very quickly show your bio to the cool beans here, and then we will start our discussion. So if you give me one quick second. So cool beans, this is Drbeen.com. This, I believe everybody is aware, this is FLCCC site. This is the physicians list. And as you've seen, Dr. Paul Marik, Dr. Pierre Corey, Dr. Madhuri, Dr. Joseph Varun over here, Iglesias, and so on, Dr. Iglesias. Here is Dr. Varun's. If you go to the site and you click here for the curriculum vitae, this is the bio, and you can see that this is a multi-page bio. So I won't go over all of it. However, I want to quickly show you some parts that are important to look at. So Dr. Varun is the chairman of the board of United Memorial Medical Center and United General Hospital. And before I discuss some more of his bio, he has done 1,800 interviews since March of last year. So I am sure that many of you are already aware of him, but this is just to be on the same page. He is a chief of staff and chief of critical care at United Memorial Medical Center and United General Hospital in Houston, Texas. In addition, he's a chief of staff at UMMC North and UMMC Sugar Land Hospital. He is a former chief of critical care services and past chief of staff at University General Hospital. And this continues, and I have some things that I've highlighted. Dr. Varun also has served as a fellow in critical care medicine and pulmonary disease at Baylor College of Medicine in Houston. Huge deal. An avid researcher, he has contributed to more than 830 peer-reviewed journal articles, 10 full textbooks, and 15 dozen book chapters. He's also a reviewer of multiple journals. Dr. Varun has won many prestigious awards and is considered among the top doctors. Actually, when Joseph said yes for the interview, that was a big celebration for us because he is a celebrity in medical world. So check this out. The selective brain cooling and hypertensive crisis management with hypothermia. So he co-described the hypothermia associated to extreme exercise syndrome, also known as the Varun-Ayers syndrome, and with Mr. James Boston, so co-described the healthcare provider anxiety syndrome, also known as Boston-Varun syndrome. And it continues. Dr. Varun also is a world leader for his work on COVID-19 and his co-development of the Math Plus protocol to care for these patients. For this, he has won multiple awards, including proclamation by the mayor of the city of Houston of the Dr. Joseph Varun Day. And this all the good work, as they say, no good deed goes unpunished. He is also being chased by folks as well to say, how dare you use some of the medicines for COVID management. And we were discussing before this that he also gets death threats too, just like I have been getting them too. So Dr. Varun, welcome to the club and thank you very much for being here. Can you please tell us a little bit about yourself? After this, your work, your day-to-day life.
Very simple. Born and raised in Mexico, went to school in Mexico, did residency at Stanford University, then fellowships at Baylor College of Medicine, boarded in several specialties, but my passion is the management of the critically ill patient. So when COVID hit, I was able to use many of my specialties. I mean, from critical care, pulmonary medicine, internal medicine, to deal with these patients. And I had the administrative skills after being chief of staff and being a couple of other things. So for me, COVID was something that really came straight into my arms.
Got it. Thank you very much. And behind you, I see a lot of fountain pens. Is this a museum for the fountain? What is this? Can you tell us?
I mean, I collect fountain pens. I've been collecting fountain pens for several decades, and I love fountain pens. For example, I have a pen that instead of a clip, this kind of clip, it has a key. And that key is the key that Harry Houdini used to use to open up his handcuffs. I have another one that on the cap has a hair, a real hair inside the cap. And that hair is an original hair of President Abraham Lincoln. So I love fountain pens. I don't write with anything that is not fountain pens. And yes, this is like my mini museum at home. It's my office. I love it. I mean, you know how people, they collect cars and they collect other things. I collect fountain pens.
Oh, wow. Beautiful. And we were talking about Luffy and Kyrie, that are my cats. And I said that, hey, heads up, they might show up. And you told me that you actually, your family is a animal lovers family as well. Can you tell me about the furry friends you have?
Yeah, I guess that, that's the reason why my wife married me, because she loves animals. We have, at the present time, we used to have, at some point in time, we have 8 dogs. We currently have only 5 dogs. We have 2 parrots, giant parrots. We have 4 chicken in the back of the home that produce eggs on regular basis. So we are into that. And we have fish. And I'll tell you, my dogs are like part of the family. I mean, really, I will take food away from my food to give it to them because I like them so much.
Very good. So thank you very much for this. So you won't mind if Luffy shows up and becomes part of the conversation as well. So on the COVID side, if we can focus, the structure that I have been using to discuss COVID management with doctors has been, we talk about prophylaxis, then we talk about ambulatory or outpatient management of COVID, then in hospital management of COVID, maybe in ICU and critical care, and then finally any post-COVID or long haul syndrome. So if you are ready, shall we start?
Absolutely.
Okay.
By all means.
So let's start with this. And we have a number of questions on Twitter. We will have a bunch of questions here with this broadcast as well. And with your permission, I'll ask you those questions too. So starting with the prophylaxis, have you been managing your patients with prophylaxis? If so, what is that? Or have you been doing any prophylaxis for yourself and your family? And what is that?
Well, I mean, the fact is that, as you know, I have been very involved in the studying and utilization of ivermectin. So I have been using ivermectin both personally as well as for all my patients. And when people started to realize that I was using ivermectin, and with the lack of many doctors doing this, I started to have even more and more patients. I've had the opportunity to talk to several of my colleagues in other countries where we have helped them, or we have influenced to some extent the use of prophylactic ivermectin, and they've had a great success.
Got it. And with the ivermectin, do you also look for correct vitamin D levels, or hydroxy, or zinc, or quercetin, or is ivermectin your mainstay for prophylaxis?
Well, I mean, the one thing that you need to understand is that there is no single medication, no single drug that is capable of keeping you 100% protected. We know from the very early stages of this illness, when we first started to learn about this, that those people that had low vitamin D levels, for example, and I know that Paul Marik has talked about this in your show, people with low vitamin D levels were having issues. I mean, we were perplexed to find out that the north part of the United States were having much more deaths than the lower part of the United States. And we recognize that we in the South tend to have more sun exposure than people in the North. So eventually, it became clear that low vitamin D levels were associated to higher morbidity and higher mortality. We have been, as you know, also quite significant proponents of vitamin C. I mean, good doses of vitamin C and quercetin. We have also been advocating it. And I don't use the zinc that much. My colleagues do. I think that, a good dose of ivermectin, your vitamin D, vitamin C, that usually takes care of things. Now, if you want to go one step further, try to get a little bit more of immunomodulation and use a little bit of melatonin. And I'm sure that Paul mentioned this at some point in time, but the way we came about melatonin was that the animal on Earth that has the highest amount of coronavirus is the bat. But yet bats don't get sick with COVID. And what's really interesting is that bats have the highest amount of melatonin of any animal. So, I mean, at the beginning, that's how some of these things came about. And then obviously, some true science, if you want to call it, evolved. But that's my basic preventions. However, there is no good prevention without basic common sense, which, by the way, is not that common. Mask. I mean, I think that people need to wear masks. I mean, that will prevent. But for masks to work, it needs to be both ways. It cannot just be one way. For my mask to work, which is what I call social conscience, you have to wear the mask to prevent the other person to getting ill, but at the same time, the other person needs to wear it. I mean, it's a two-way street. Avoiding going to crowded places. I mean, what I'm seeing today in my unit is a 4th of July disaster. I mean, as I was telling you before we went on live, I mean, I've had a 500% increase in my number of admissions in the last 10 days. I mean, it's ridiculous what's going on in the Houston metropolitan area.
And is that mostly vaccinated folks, unvaccinated folks, or you do not know, or there is a mixture? Do you have some observation there?
Yes, I do. Actually, anybody that comes in, the first question that I ask before I even ask them their name, I actually ask them, are you vaccinated? Up until yesterday, I would have told you it was a disease of 100% unvaccinated people. However, yesterday I had my first vaccinated patient admitted to the hospital, a young woman who got the Johnson & Johnson vaccine in the month of May and came to the hospital with 10 days of symptoms, which is not uncommon among our patients. Most of our patients come in with about 2 to 2.5 weeks of symptoms before they show into our emergency room.
Got it. And so we'll talk about the emergency in a second as well. Do you see that with the newer variants, are you observing a more intense disease course, or similar as before, or milder disease course? What is your observation compared to, let's say, 8-10 months ago?
That's a great question. And that's a loaded question. And the reason why it's a loaded question is because people have developed what I call the COVID fatigue syndrome. They're tired of COVID. They forget about COVID. And when I compare my patients today as compared to a year ago, most of the patients that I get today have longer periods of symptoms before they come to the hospital. So to some extent, yes, these people are much sicker, but they're sicker because they waited longer. I'm not sure that it's the variant itself, the one that's doing this. I think that people are just neglecting that they may have COVID. They forget to get tested, or they say it's not a big deal. And then by the time they come to me, they are in acute respiratory failure, and we got to do all the stuff that we have to do.
Got it. Thank you very much. So there is a question that has been asked of me many times about FLCCC, and the Twitter thread where I requested to collect questions for you as well. There is a common question that is there that has been asked to me before as well. So without offending you, is FLCCC has a position on vaccines to say, don't get vaccines, or do get vaccines, or some other position? Do you have, what is your opinion or can you represent also FLCCC or just yourself about vaccines?
As a founding member of FLCCC, the first thing that I will tell you is that our primary goal was to save lives. How we saved them, what routes we used, each one of us contributed them. Within the core group of FLCCC, you have people that are 100% pro-vaccines, other ones that are not so much pro-vaccines. But what we do understand is that vaccines, they may not be perfect, but when you look at the greater good, right now it's like the one option that we have, because ivermectin is probably not 100% what we would fix. The one thing that we know is that eventually we're going to have all to get immunity. The way I tell people this is like, there are two kinds of people in this world. Those that have COVID and those that are going to get COVID. We all are going to get it sooner or later. So I do believe that getting immunization makes sense. Now, as FLCCC, we realized that getting immunization was going to be very difficult. I mean, I cannot convince 40% of my nurses in my hospital to get vaccinated, even nurses that work on COVID. So what do? Well, FLCCC provides with all the information that we have on, for example, ivermectin. And ivermectin buys you time while either we get better treatments or we get people convinced to get the vaccine. And as I said, the different members that conform the core group of FLCCC, we all have different opinions. But what we do know is that at least ivermectin is buying us time so that people can get vaccinated.
Got it. Thank you very much. And I want to add my comment here as well. I think that from a medical doctor's point of view, when folks hope that we doctors should take a position to become anti-vaxxers or become pro-vaxxers, I think that is not possible. If you look at from medical as a profession, a doctor has to, as you said, save lives. And for that, all tools that would help save lives should be used. That include ivermectin, that include many other things as well, that includes masks as well, and that includes vaccines too.
What has happened is that, this illness has been politicized up to the wazoo. And we're not dealing here with science or true medicine. I mean, here we're dealing with political interest, we're dealing with economical interest, and we're forgetting about the most important thing, which is the patient. As clinicians, we have to think about the patient. And, maybe the vaccine is not good for some patients, but it may be good for others. And again, you need to look at the greater good. What can we do to help these patients? I am a big believer, and you and me, we live in this country because we believe in freedom of choice, freedom of speech. And I believe that somebody does not want to get vaccinated, they have the right to say, I cannot get vaccinated, just don't get close to me, or, be away from me so that either I don't get you sick or you don't get me sick.
Totally understandable. Thank you very much. And this is a very common question. And I think that a doctor cannot take that position to become anti-vaxxer or pro-vaxxer. Question. So I wanted to go from prophylaxis onwards, but while we're talking about vaccines, I have a question that is important. We are seeing, for example, in certain vaccines and certain groups, they get, let's say, women under 50 with adenovirus-based vaccines, so far at least, what I know, getting clotting, some of them. Similarly, under 30 years of age, messenger RNA type vaccines causing cardiac inflammation, some of the patients under 30 years of age, men. Have you seen any post-vaccine acute injuries where people end up in the hospital with them?
I have not seen anything that brings a patient to the hospital. I have not seen, the venous thrombosis that is commonly alleged, or even the cardiomyopathies. And I want your viewers to be alert. I mean, these things can happen independently of the vaccines. I, at the present time, don't have a true feeling as to what is caused by the vaccine and what is just a temporal association. And I don't think anybody can tell either way. The number of cardiomyopathies or myocarditis that has been seen in young people, particularly young males. I mean, every year we have some degree of viral cardiomyopathies. How much of that is coincidence? How much of that is vaccine related? I just don't know. So yes, I would suggest that those individuals in those age groups, those people which may be considered to some extent to have high risk factors, there needs to be a discussion with the healthcare provider. It needs to be very open, very transparent as to what are the risks and potential problems like the ones that we mentioned. And again, look at what's going to help me more. I mean, am I going to get in trouble with the vaccine or not?
Makes sense. Thank you very much. So if I now switch back towards the prophylaxis and the next phase. So let's say, moving on from prophylaxis, somebody has COVID, they just got it. And from the discussion, it seems like most of the patients that you're seeing, they probably are reaching you after 8-10 days of symptoms. But let's say if I got symptoms today and I contacted you, what is your advice to me? How would you manage me? Would you ask me to stay at home and wait, or would you give me ivermectin or something? What is the approach for acute patients? And I know that by acute, I mean ambulatory patients.
We have, as part of FLCCC, we created the eye mask protocol, which basically has the either prophylactics or the active treatment. And the treatment varies depending on how are you doing. I mean, we try to keep patients at home whenever possible. The outpatient treatment is relatively easy. I mean, if you have not been to our website, I suggest that you be to our website. We have the protocols are translated to multiple different languages so that people can understand it. But the early outpatient protocol is fairly straightforward. We use ivermectin. We do use fluvoxamine, and I know you guys have discussed this in the past. We use the vitamins that we were talking about earlier, vitamin D, vitamin C, quercetin. We do use zinc, melatonin, and again, as an immunomodulator. We recommend aspirin, but more importantly, we educate our patients to, monitor their pulse oximetry. And if the oxygen goes down, then, we go to the next step. But we have been working on this, and this works. We give doses of ivermectin, which are reasonable. And many times you get a phone call from the pharmacy that says, what in the world are you doing? Where is the parasite? And you said, it's not a parasite, it's a virus. But, we deal with those things. We have talked about nasopharyngeal sanitation, as a secondary kind of therapeutic intervention with some steamed essential oil inhalation, because some people have mentioned that works, or if you like to do things like Vaporub or something like that, that may work, or even some betadine nasal spray 2 to 3 times a day. Those things work, not only help you eliminate the virus, but also prevents you from spreading it to others.
Got it. And tell me, do you suggest, prescribe, or have any comment on using things like budesonide or steroid early, late? What is your comment?
I try not to use them unless there are changes in oxygenation. But as I will tell you, when we talk about the hospital admitted patients, I mean, I use a special scoring system that we have actually validated, that depending on what your CAT scan looks like, that's how I decide whether or not I give you corticosteroids.
Got it. So this is the ambulatory, or this is the outpatient patient management. Do you believe in aggressive early treatment? Of course, here is a list, and you have participated in building this list. So should it start as soon as the symptoms are seen?
Without question about it. From my standpoint, those patients, and again, I have seen a few thousand patients now with COVID, and I can tell you that the sooner you start the treatment, the more chances of, number one, avoiding getting hospitalized, and number two, that you will avoid the long haul syndrome.
Got it. Thank you very much. And this is my experience as well. Now moving to in-hospital. So tell me this, a patient who ends up in the hospital, let's say they ended up because their oxygen levels are dropping, and they may or may not be on this. So the first question on this, meaning imath plus or ivermectin, many patients will not have it. So my first question is, have you any observation for if somebody was taking ivermectin for prophylaxis or during acute disease, what are their chances to end up in a hospital versus somebody who was waiting at home and has now become a little degraded?
Actually, that's a great question, and I do have some experience with that, and I'm going to give you at least a scientific experience. One of my friends owns an airline company in Mexico, and this gentleman, when I told him that I was starting to use ivermectin, he basically got all his employees to start taking prophylactic ivermectin. Prior to that, he had 4,000 employees. Prior to that, his employees were not taking anything, and he was getting anywhere between 2 and 3 deaths per month. I mean, a lot of people hospitalized, but 2 or 3 were dying without question about it. After he instituted giving ivermectin, not a single one of them ended up dead, and there were only a couple of admissions to the hospital. So it works. Now, for those who were ill and didn't require hospitalization, not a single one of them ended up in the hospital either. We're actually looking at the data as we speak, and we're hoping to get this out as a publication.
Got it. So a little political question here. 2 questions, and totally up to you to pass on them or tackle them. One is, why is so much resistance against ivermectin when there is so much experience by those who use it that they're saying every day that, hey, we see it working? What is your thought for why that is happening?
Well, I think that you can go into conspiracy theories here. You can do a lot of things. I mean, you can say, is big pharma trying to, the remdesivirs of the world are trying to get rid of the little, $10 medication. That's one thing. But believe it or not, our own colleagues have been also very difficult to convince. They are still waiting for the randomized placebo-controlled trials. And I am sorry, I'm not going to put any of my pressures on a placebo because I know that ivermectin works. It doesn't make any sense. It's like you and me were talking about hypothermia. I know that hypothermia works. I'm not just going to put 50% of my patients off hypothermia just to show it if it works, because I've been seeing it work for a long period of time. So reluctance from our own colleagues, clearly some political and economical things are there. I will not venture to tell you which ones they are. I mean, that's beyond my pay grade.
Got it. So then another political question. Your own eye mask plus protocol, how well received or not well received it is within the hospital networks or the hospitals around you? How do you see its success?
Well, it's not. Unfortunately, it's not. I work at a small community hospital. I have worked in the big hospitals for many years, but big hospitals, big politics. So small hospitals, you can do your work. And when the big hospitals see that you are doing something like what we do, they don't like it, and you get your share of political issues. As we will discuss, our success rate with the Math Plus protocol has been amazing. We have mortality rates that are very, very low.
Got it. And my own experience, again, my experience is not a study, or maybe you are putting your experience together in a study or not. My own experience has been that this is a very successful protocol as well. My question to you, so if this is the situation in the US, which country or countries have you seen this protocol to be well received and successful?
We've seen a lot of countries where they have used either the protocol or variations of the protocol, such as Bangladesh, India, Egypt, Colombia, Peru, Mexico. I mean, recently Mexico, especially Mexico City and the area surrounding Mexico City, decided to go ahead, and those people that work for the Social Security Administration in Mexico started to receive ivermectin, and the number of cases dropped. Even the patients that eventually were admitted, their mortality was much, much lower. So this is not just the US. This is being done in other countries around the world on people that are willing to try. We're in the middle of a pandemic where people are dying, and we need to be able to provide them with something. You don't have time for a large, controlled, randomized trial. And as I said, ethically, I would not even do it at this present time because I know that it's working.
It totally makes sense. One more question before we go to the ICU or critical care management side of it. Vitamin C. Is oral vitamin C as good as IV, or oral high dose also sufficient, or somebody who is not yet in a hospital but is becoming acute? Should they go get IV, or should they go to a hospital? What is the difference between oral versus infused?
Well, again, the first thing that you need to make sure is that you don't fall into the trap of a lot of docs out there that they give you vitamin C to feel better in general. I mean, because as you know, there have been some cases, especially in the Chicago area, where they were shut down because they were doing a little bit of hocus pocus. Vitamin C absorption in the GI tract is reasonable, but it's not perfect. If you truly want to achieve high vitamin C levels, you have to do an IV infusion, even if you double or even triple the vitamin C. And Paul Marik, as you know, he's like the world leader on vitamin C. We use very high doses of vitamin C on our patients in hospital, and also as we will discuss when we do the Math Plus protocol. I mean, there are some patients, actually most of my patients that are very sick, they're on 25 grams of intravenous vitamin C every 12 hours.
Wow. So let's then, and the reason I ask this question, for the healthcare professionals who are watching this and who may not be in US, or who may be at liberty to be able to see that, do they need to prescribe oral versus IV, or if they can inject it in their clinics or those. So please realize that IV may be actually a better outcome, will have a better outcome.
We actually have done that. I mean, if we get you early with COVID, and we don't believe that you need to be admitted to a hospital, but you are symptomatic, we will offer you to go to one of our infusion sites to get vitamin C, at least to load you up with vitamin C, and then follow that up with PO vitamin C.
Wow, this is great. So this is what your center is doing.
Correct. That's and again, we've been doing this now for more than a year.
Wow, that is excellent. Thank you very much for informing that, because many hospitals are not doing these things. So now if we go to the critical care. So let's say somebody has been neglecting or did not get controlled by the other medicines. Now they're in a situation where the oxygen has dropped, they have enough dyspnea, they've reached you in the critical care. How do you approach a patient who is in critical care with the current variants? Is there a difference in management with, let's say, Delta variant or more modern variants compared to last year?
Okay, so number one, there is no difference as to how we manage patients based on variant. So that's simple. So I don't even need to know what kind of variant the patient has, because it's not going to make a difference. Now, the way I approach the patients is a little different than some people do. First, if you come to a hospital with symptoms of COVID, you get a CAT scan of your chest. Simple as that. Forget about the chest X-ray. I skip the chest X-ray. I go straight to the CAT scan. On the CAT scan, what we do is we basically map out how much COVID you have in your lungs using a scoring system that's called the Ichikawa scoring system. The Ichikawa system is a system that was developed for ARDS in the year 2006, has not been used for many years, but I decided to apply it to it. Then the Ichikawa score goes from 0, which would be your perfectly normal scan, all the way up to 300, and 300 is, completely white out. And what we have actually been able to validate was that when we apply this scoring system, if your score is more than 220, you have a very high chance that you may die. So on the basis of what the score is, I then decide how to best give the Math Plus protocol. Remember that protocol that we created over a year ago? We started using it in March of last year. And the Math Plus protocol really focuses on the treatment of the two important factors that we have in COVID: inflammation and coagulation. And more recently, now we've been working also on immunomodulation. But what we do is we basically blast the patients with corticosteroids to help them out based on, number one, how much oxygen requirements they have. Number two, what kind of Ichikawa score they have, and so on. And as you can see on the image that you are projecting, I mean, we have a stepwise approach. I mean, we usually start with 80 milligrams of methylprednisolone, as you have discussed with some of the other FLCC members in the past. Methylprednisolone by far is the best corticosteroid to use in these patients. We know that COVID is a very steroid-sensitive illness, so we use anywhere between 80 milligrams and a gram every day, depending on the patient.
Got it. And then there is this ascorbic acid, thiamine, heparin. Is this all necessary, or is this all based on some labs? How do you continue to help?
Well, the fact is, as I told you, what we're trying to do is improve the inflammation and decrease the chances of clotting. So this is not too much based on labs. We base this on each patient is individual. We do anything that we have to, depending on how sick they are. The heparin, as you know, has been a little controversial as to whether you should do full dose or low dose. But we monitor our patients. We give them about 1 milligram per kg of low molecular weight heparin, and we try to monitor anti-10A levels and see where they are. But the patients may be quite ill, may be requiring ICU, so we obviously try to increase the doses as needed.
Got it. And there is a question here. Let me just quickly project that question. It is related to this phase. So Arun Mehta says, leronlimab, tocilizumab, IVIG, we cannot ignore it. So are any of those used here as well?
Well, no, they are not, and for a variety of reasons. Number one, in our experience, when we use tocilizumab, most of our patients were getting secondary bacterial infections, and they were getting very, very ill. Even though there are some pro-TOSI papers and some papers against TOSI, at the present time, I don't think that I have enough information that would suggest that should be used. IVIG, again, the data on that is all over the place. And what you see on our Math Plus protocol is based on data that is reproducible, data that is being shown over and over and over to wait. Now, so that you guys know, I have tried everything that you have mentioned. I used to put my patients, every patient that came in, obviously the sick ones, we would start them on TOSI or one of those. We've tried the IVIG. I didn't see any changes on these patients.
Got it. So tell me this, how has plasma exchange been working?
Well, plasma exchange, I don't do it at my institution, but Dr. Paul Marik swears by it, and that's why we have included. I have not used it, but it may or may not be good.
So two more questions. One is about ciproheptadine. So we have ciproheptadine here. Have you been using it regularly? What is your opinion or observation with that?
If you come into the hospital with an Ichikawa score of more than 200, you go on everything that you see there, basically. And ciproheptadine, you remember, this is a shotgun approach, but these patients are very sick. And what you are trying to do is to attack the illness by different areas. You are not trying to go on, let's just go ahead and that's, the failure of, for example, of remdesivir, that they just wants to go against the virus. Forget about the virus. By the time you come to a hospital, the virus is long gone.
Correct. So now it is the inflammatory state. One thought that or curiosity that I have now for about a year or more, and I have read some studies as well, has not gotten any satisfactory answer. And that is, who becomes severe? So is there some way of telling that if I got COVID, I will become severe or I will not become severe?
Yes, what we were able to find was those patients that had a high Chicago score in addition to an elevated CRP of more than whatever is the highest level that you can get in your lab. Those were the patients that were getting in trouble. We also look at interleukin 6 on these patients. And one thing that was very interesting is that from the very first day of that I started working on COVID, I started getting CD4 counts on my patients. And interestingly enough, the vast majority of these patients were having CD4 counts way below 200, kind of like a short-term HIV illness. Actually, for those who believe in conspiracy theories, that may be one of those that people think that, that was a man-made virus. But if you have a very low CD4 count, if you have a high CRP, if you have a very high interleukin 6 and an interleukin 10, and you have a bad CAT scan, your chances that you will not survive are very high.
Got it. And talking more about the CD4, and probably with that, there is neutrophil count abnormality as well. Do you have a reason in your mind, or have you read up some studies about why the CD4 helper cells go down?
Well, your bone marrow gets completely messed up. Remember, you have that immune dysregulation that Dr. Marik has talked about over and over again. I mean, we know, for example, that these patients are eosinopenic, completely eosinopenic. If I have a patient that has an eosinophil count of more than 1%, I can tell you that patient does not have COVID. Simple as that. We know that the way the neutrophils start marginating, it's impaired. And that has been shown over and over again in these patients.
Got it. So the last phase of the management part, and then we'll go to the audience questions as well, if you have time. Long COVID. So once again, I'll start with this. Can you predict who will end up with the long COVID?
I can't, because as you know, in those people that have symptomatic COVID, anywhere between 40 and 50% of them are going to have long-term symptoms. I tend to see more of these in those patients that were admitted to the hospital. But still, we see a lot of people. I mean, I just today, before I came to do this, I saw two individuals that have classic long COVID. And the biggest problem on that is that these are going to be patients that will have this illness that can impair their life. I mean, impair their lifestyle. They may not be wearing oxygen, but they have all these recurrent headaches. They have numbness in the fingers. I mean, these people are very miserable.
Absolutely. And what I'm seeing is that the youngsters are actually suffering more. And I think one of the reasons is that they are more active as well. And long COVID somehow seems to be more intense in active people. And secondly, youngsters do not expect them to be out of commission like that. So they become even more miserable. But I'm seeing this to be in all ages. The question for you, the long COVID protocol, how do you approach management? And I know that there is a protocol there as well. I'm going to show it.
Yeah, so we have what we have created, the so-called iRecover. And this is nothing that has to do with Apple or Mac or stuff like that. The iRecover protocol, which is a protocol that we created mostly to manage this long-haul COVID syndrome. We go back to the use of ivermectin. And why, again, ivermectin has a lot of great properties, and that anti-inflammatory, chronic anti-inflammatory illness. Remember, this is an agent that helps you a lot. I mean, if you have a patient that has anosmia, which is something interesting, you actually have to give a little more ivermectin. So what we do is we give ivermectin anywhere between 3 and 5 days. And then after that, we go either twice a week or once a week and see what happens over time. If the patients do better, which many of them will do, once they are doing better and they have no more symptoms, we continue it maybe for a couple of weeks, and that's it. I mean, after giving ivermectin, if you happen to have any neurological symptom, then we start you on the SSRI fluvoxamine. if a patient comes with any kind of dyspnea or hypoxemia, well, we do repeat the CT. We want to make sure that they what's going on. Remember, these patients can get or they get organizing pneumonia, so we need to get an idea of where they are, and then make a decision whether they need steroids. And steroids are usually, I call it a rescue therapy, and they tend to do okay. Every patient gets the usual vitamin C's. We give the atorvastatin, remember, as a distal capillary anti-inflammatory agent. We give stuff like that. If we suspect that the patient has mast cell activation syndrome, which does happen, then we usually give them either a type 1 or a type 2 antihistamine. We make sure that these people know what a low histamine diet is. We have used mast cell stabilizers, sometimes difficult to use. A lot of second-line agents such as montelukast, which has worked. Naltrexone has actually also been used, diazepam, SSRI. So we give a lot of additional medications because this is such a complex entity. Like I told you, it's not a single agent that's going to cure it overnight.
Got it. And I know that this is relatively new. I am happy that even my name is over here. Have you been getting any feedback for how it has been working?
Yes, I mean, I can just tell you on my own experience with my patients. I mean, they within a couple of weeks, patient says, "I can't believe it. I've been having symptoms for 8 months, and then I come to you, and it's working." So it's very encouraging. It's very, very encouraging. I mean, again, like you said, no good deed goes unpunished. I mean, there are people that really don't like what we're doing, and what can I say?
I think that if there is a place where all aspects of COVID management can be seen in one place, and where a doctor or a healthcare worker can see what are various options at various phases of the disease, that is FLCCC. I have not seen any other place, including places like WHOs and CDCs and FDAs and NIH. I have not seen such a comprehensive approach to management.
Well, what happens is that we recognize it because we saw it. And, with all the respect that the CDC, the NIH, and everybody else had, they have not taken care of patients. I mean, even the leaders at CDC, they've not taken care of a single patient with COVID. We are seeing these patients. We see what works. We see what doesn't work. We also understand these phases. I mean, that preliminary or that viremic phase, and then how you go to the different stages. And we know what works. The one thing that has been at least fundamental for me is to see that the one medication that works in the different stages of COVID has been ivermectin.
Yeah, absolutely. And I want to share this with Cool Beans and with you. The long COVID protocol, when it was being developed, a major part of that is developed by my work and some more doctors. But more importantly, Cool Beans here, who are right now the audience here, I remember that we went over various components of it before it was put up, and we discussed various parts of the long COVID protocol and how that has been working for various people. So I think that then Dr. Tess Laurie's work with the mast cell, and Dr. Bruce Patterson and Dr. Yo's work, then Dr. Paul Marrick's work and your work for the macrophage activation, all of that came together to create this protocol. I think I have not seen any protocol that comprehensive for approaching long COVID.
And again, please understand that we all have, like I told you, the same passion. I mean, none of us are being funded by any kind of pharmaceutical industry or the ivermectin people or whatever. I mean, we actually do this because we want to save as many lives as we can. We want our families to be able to continue to live in this planet. And, things are not that easy when the rest of our colleagues are not paying the specific attention that we have. This attention to details, from staging, from different, multi-medication approach to control this illness, actually to control the illness, even from a preventive standpoint, I mean, the reason why we call it the eye mask protocol is because of the mask, because of we recognize the importance of masks to prevent other things.
Got it. So thank you very much. I think this is the most comprehensive discussion for the management part of it. Now, if you are comfortable, and Luffy is here, so don't mind if you hear him chiming. He's here to tell us that the next phase of the talk should start now. And this is where the audience come in. Luffy is one of the audience members. Are you comfortable? If you have time, we continue with some questions.
Absolutely, I'll be happy to do it. And if you want, I can get my dogs to start barking at your cat.
Absolutely, that will be awesome. Luffy, for once, as you can hear, he's not a Siamese cat. He's a Bengal cat. He's not hungry either. His food is actually always open, but he just woke up. And whenever he sees me speaking, he feels that he has to add as well. So I would love to see the dogs as well.
I mean, so, I just want to know what his question is so I can try to answer it.
I think he is here to say that you guys are on the right track.
Yes.
Okay, so some questions from the Twitter. Avox Mocha Bean says, it seems to me that the US government has the greatest resources but contributes little. US COVID strategy has not evolved since the start of the vaccine. And have they anything yet for long haulers? If you could direct their vast resources, what would you have them be doing?
Wow, that's a great question because, it's politically charged. First, remember, the way I see medicine, unfortunately, in the United States, it's 100% political. Come on, look at what's been going on over the whole year. If I could get those resources, definitely I would go at the different parts of COVID, and I would do a huge educational effort at prevention. Because if we can prevent, then we don't need to be talking as to putting patients on hypothermia or prone ventilation or ECMOs or stuff like that. So I would really go to the preventive part. Now, from a medication research standpoint, we have a medication that we know works. So it's like, I'm sure you know that, Merck gets this, I don't know how much money, $1.2 billion or so, to develop a medication that is exactly the same as ivermectin. So come on.
Absolutely. So molnupiravir is according to the information so far, it is an RDRP blocker, which is one of the functions of ivermectin. Ivermectin has more functions. There was a question here from Ravi Thija. He said, second dose of Covaxin. So I believe Covaxin is inactivated virus, triggered chickenpox. So have you actually seen vaccines or COVID itself triggering other pathogenic diseases, other infectious diseases?
I have not. I have read a few cases, but again, you don't know how much of that is coincidental. I mean, it's like the person that tells you that they got COVID the same day that they got the vaccine placed. So again, how much of that is a real thing?
Got it. So Mr. Wines says, FLCCC recommends full dose aspirin, 325 milligram in eye mask plus protocol with fluvoxamine and melatonin from day one of diagnosis. Is there any possible risk of bleeding? Also, why no mention of Plavix? Thanks.
Okay, so quite an easy question, because when you do the balance of what you have, clotting or bleeding, I mean, almost nobody dies from bleeding. I mean, you can always transfuse, you can always do things. However, you get thrombosed, and that's it. Hasta la vista, baby. So I think that when you are looking at the risk benefit of giving somebody an aspirin is actually minimal. I mean, we have been doing this for years for prevention of heart things. The American Heart Association has been pushing it for forever. Now, as far as Plavix, there were some studies looking at Plavix, but I'm not aware of any study that has ever shown that Plavix is superior to aspirin in the context of COVID. And as you know, Plavix does have a much higher bleeding risk than plain old aspirin.
Got it. Thank you very much. And Joseph, it is not lost on me for your time and insights and the experience and the result of experience that you're sharing here, this in itself is a huge service to humanity. There are many people, healthcare workers, who would listen to this, they would take notes, and they would go and manage patients and save them. So thank you very much for doing this. Michael DG says, my friend is in his early 60s and has been undergoing treatment for a small but aggressive brain tumor during the past year, including radiotherapy. Is it normally recommended that cancer patients be vaccinated? What would Dr. Varun and Dr. Mubin normally recommend, Michael?
Well, my recommendation is that they would get vaccinated. And again, the reason for that is that the populations at risk, the ones that are going to get in trouble, are those people that have comorbidities. And a malignancy is a comorbidity. Now, unfortunately, those patients with cancer that get vaccinated may not mount a good enough immunological response. And in those patients that I have in my practice that have been vaccinated and have some kind of malignancy, I do follow antibody levels to get an idea if they're going to need to have another booster of the shot.
Got it. So I would have a similar recommendation, Michael. The additional point that I might take from the Netherlands study, that there were some patients in Netherlands study who were critically ill, and they were already terminally ill. And this was a matter of a few weeks. And then vaccine caused side effects, for example, nausea and diarrhea, and they could not go through that, and it caused some of them to die. So important is to talk with their doctor to see how is the health of the person, and then discuss further. So Andre de Bale, hey, I hope I pronounced correctly. What kind of a vaccine side effects are you seeing? Is leg numbness one? How might it be treated?
Well, I mean, yes, we have seen all sorts of numbness. I mean, leg numbness, arm numbness, all the numbnesses that you can possibly imagine. How much of that is supratentorial? I mean, how much of that is just all this hype of what can happen, and how much of that is real is difficult to tell. We actually have had a couple of patients where we actually use ivermectin after the vaccine, and that had a couple of neurological symptoms. The patients did relatively fine, but I'm not sure if it was the ivermectin doing the trick, or, like I said, is there something else going on up here on these patients? But yes, neurological complications have been reported with all the vaccines.
Got it. Thank you very much for this. Dio says, why are those of us COVID survivors given any recognition for our natural immunity? I think she's saying, why aren't we worked hard for those antibodies? We surely have different considerations. So the question is, people are asked to take their vaccines or to have that passport or eligibility to go to various places. Those who were naturally infected and have recovered, should they not be allowed to participate just the same?
Again, this is another good political debate. And I will tell you, I mean, for that to happen, then you would have to show that you have good antibody levels. Because, for example, today, one of my friends who's an infectious disease doctor was telling me he got his 2 vaccines, his 2 Moderna vaccines. He got his levels just last week, and he has almost no antibodies. Yet he has his vaccination card, so he can go to places with his vaccination card. But the man has the potential to infect a lot of people and get infected as well. So the one way by which we could potentially deal with this is for people to get antibody levels. But let's be clear, that is not easy to do when you're talking about, millions and more millions of people.
Got it. Thank you. Dr. Eric Osgood, MD. I think you know him. He's part of FLCCC as well. So question for you, Luffy, does he have a bean name? So Joseph, do you have a bean name?
I don't. Do you want to give me one?
Absolutely. So
Absolutely.
Tell me.
I mean, I'm the COVID hunter, so feel free to just throw in whatever you want.
So Dr. Paul Merrick is an emperor bean,
okay,
and a soy bean.
Okay.
Dr. Corey is a coffee bean. I am a servant bean. So you decide.
No. You are the bean master, so I will be delighted to get any name you give me.
How about critical bean? Because you've been working with it.
I'll be the critical bean. There you go. Perfect. I like it.
Yeah.
Consider
So
it done.
we will get that registered and send it over to you. In addition to that, so Iglesias would be kidney bean, so we'll work on that. So next question, James Merrick says, have anyone found a correlation between low vitamin D levels in African Americans and higher severity of COVID?
Actually, yes, there have been a couple of papers that have shown that, but again, there have been mostly in the northern parts of the country, and the lower your vitamin D levels are, the higher your severity of COVID is.
Got it. Thank you. Charlotte Meir says, how long will the ill effect of the vaccine last in the body? Someday lasting deferment will occur. But if the strength of the vaccine is short-lived, how about its collateral damage? Does not the body have its own repair system?
We don't know. That's as simple as that. I mean, anybody that tells you that they know, or any company that comes and tells you, well, we need to, give you another vaccine, or how long this vaccine is going to stick around, we just don't know. I mean, I remember, at 6 months after Pfizer had started vaccinating people, they says, oh, people are going to need another booster because our vaccine only lasts for 6 months. Well, it lasted 6 months because you had only been given it for 6 months. However, some of the new studies, and I'm sure that you're familiar with the study from Nature, shows that all the mRNA vaccines actually have what appears to be a little longer lasting immunity. So, the jury is still out as to when and how long will this last for.
Got it. Thank you very much. LK3T says, what is the actual percentage of vaccine breakthrough infections? Is there any need for concern?
Well, I don't have the exact data, but I can tell you that there is a paper that was just published recently out of Israel, where they had 150 patients or so that developed COVID. Now, the concerning part about what that particular study was not only that these patients had a breakthrough through the vaccine, but that their severity of illness was such that a high number of them died, even more than regular mortalities.
Got it. Thank you. Yagami's Nutsack says, has the FLCCC presented the newest protocol and ivermectin data to Dr. Fauci and company? I'd very much like to see Dr. Corey and Marek show him who the real scientists are. I think I would add your name to that as well.
Don't worry. I mean, we have been going through this for months. I mean, one of us has gone in front of Senate. I mean, I work with two with a congresswoman and with a congressman on regular basis. We try to talk to them, but it is hard. It is hard to try to change people. And again, if you believe in conspiracy theories, God knows how many of those individuals are very close to Big Pharma.
Got it. Yep. Sam says, can my 82-year-old mother with hypertension and other comorbidities take ivermectin as prophylaxis?
I would say, don't call it can. I would say she should.
Yeah, got it. So Charlotte Meir says, do you see a resurgence of COVID-19, or can 2022 be its death knell?
Well, let me put it this way. COVID is here to stay. It's not going anywhere, okay? Whether or not we have a resurgence really depends on how stupid we are. I have said from day one of this pandemic that I'm fighting two wars, a war against COVID and a war against stupidity, because we keep on repeating the same mistake over and over again. I mean, you look at what's going on out there. You look at the stadiums now that are packed with people, things like that. If we keep on doing that, if we don't put a stop, in a state, for example, let me give you an example. Houston has only 45% of fully vaccinated. 45% in a city like Houston. I mean, we are the mecca of medicine, and look at us. We have actually very poor vaccination. So if we don't vaccinate more people, if people don't adopt preventive measures such as the use of ivermectin and continue to use masks, I think that 2022 is going to keep on having COVID for all of us. And to be honest with you, I'm exhausted. I've been doing this. I think today is day 491. I didn't take a single day off for 435 days. I need a break.
I hear you. So if I ask you a question, this is the question I asked Dr. Paul Merrick as well. If today you were given a chance to say, make a decision, help us get out of it, or help us reduce the damage that is happening, what would you do?
I would tell you help prevent would be probably the best thing. The damage, once the damage is done, the damage is done. I would be more, like I told you from the beginning, I would allocate money into the early part. Prevention is much more important than fixing the damage.
Got it. Thank you. And Luffy is here. He's continuing to talk. My apologies. Carlos Ortiz says, is Dr. Varun treating patients in outpatient setting or hospital only? If doing outpatient, what kind of results is he seeing?
I see them both. I do inpatient and outpatient. At the present time, in the hospital, I have about 38 patients of mine. And in my outpatient, I see, probably a dozen patients every day.
Got it. Harry Houdini says, I thought that Yagami's nutsack was funny, but here we have a Harry Houdini as well. What recommendations do you have for someone taking a long flight 2 weeks after receiving the second messenger RNA jab? Is there increased risk of blood clots?
The first question would be, are you flying coach or economy? Economy or business, everything depends on that. But, my recommendations would be very similar to anybody else. I want you to get up and move every 2 hours at the minimum. If it's a really long flight, let's say from New York to Singapore or something like that, one of those big ones, then let's look at your risk factors. I may even give you something just on the basis of your risk factors, regardless of whether or not you got the second mRNA vaccine.
Got it. Thank you very much. Do you recommend a specific ivermectin protocol alongside the vaccines?
Yes, we do the eye mask protocol, and that's the one that I recommend. And it's a good thing to have, especially now that we don't know if some of these variants will not be covered by the vaccine. So it's good to have something extra on board. So everybody that works with me and follows what I suggest, they have been vaccinated. They are continuing to take the ivermectin because they are concerned. They are concerned about some of these variants that may not have full coverage. For example, the Lambda variant, some of the Epsilon variant that may not be as controllable. And what we do know, however, is that ivermectin will decrease your viral load and will decrease the number of viruses all over. So even if you were to get one of these weird variants, then the chances that you get an infection that causes severe illness are very low.
Got it. Thank you very much. And for the cool beans who are live right now, my apologies that I'm going through the Twitter in a more steadfast way. Usually Twitter is left out every time. So I wanted to make sure that we can answer those questions. We will come back here. And if Dr. Varun has time, we would definitely start answering your questions as well. So we'll ask, let's just continue here. So Hina says, what can we do to find a hospital that treats patients the way he does besides pray? Know of any on the East Coast?
Well, the one thing that we have been very good at is we have a huge communication department, the FLCCC. I'll tell you, I get patients transferred to me all the time. I just got a woman from California just literally 3 days ago she was flown to me. But even the FLCCC has a list of clinicians within the United States that follow and prescribe ivermectin as part of the eye mask protocol. So that's one way by which we have been trying to help people.
Got it. So Twitter for Truth had a similar, they were asking the same question. Dr. Yo, I'm sure that you are aware of him. What is Dr. Varun's spirit animal?
Well, I don't think I have a spirit animal. It may be a combination because I like them all.
Okay, perfect. So Maureen McAllister says, why would ivermectin help with brain fog?
Excellent. Well, especially in patients that have had COVID. As you know, you can have microthrombosis. You may have microinflammation. And we know that ivermectin is an anti-inflammatory agent. So that may help you with the brain fog. Although, as I said, there are also supratentorial components. And we know that some people have a lot of placebo effect in some of these things.
Got it. Thank you. LK3T says, Southwest Missouri is having a terrible surge of COVID cases. And I wonder if you are in contact with any of our doctors here that are willing to try your methods of treatment for their terribly sick patients. It's sad to see people dying when their doctor could try your ideas.
I will tell you that, that has been an issue, not just in Southwest Missouri. It's pretty much everywhere. And yes, we have contacts with them. But the problem is, these doctors many times are reluctant to use our treatments because they are scared. They are scared that their license will be compromised, that their hospital privileges will be compromised. There are medical executive committees going after doctors because they are doing some of the things that we have been doing. Now, we continue to do them because we think that that's the right thing to do. But I see how some doctors may feel a little pushback because of this.
Got it. Thank you. A few more questions here. Amber says, thoughts on taking both ivermectin and hydroxychloroquine?
First of all, let me tell you, hydroxychloroquine, I actually personally took it at some point in time when I thought I had COVID at the very beginning. And again, I wouldn't recommend people getting hydroxychloroquine unless you are having some kind of continuous electrocardiographic monitoring or some kind of stuff. Having said that, at the beginning of the illness, I'm talking about in March of last year, when I was using hydroxychloroquine, and then somebody mentioned that, hey, ivermectin could be used, I started using both, and I did not have any issues on my patients. As the time progressed, I was on both. I was giving my patients in the hospital both ivermectin and hydroxychloroquine, and I could say by the end of probably August of last year, we phased out hydroxychloroquine as more papers were being published that questioned its use. More than the political pressure that people were having, we were more looking at the science.
Got it. And just my comment as well, I started using hydroxy first. Then there was a time last, I believe, February, March time when hydroxy and ivermectin, I combined them. And then in April timeframe and onwards, I switched entirely to ivermectin. Kivini says, what is the safety and effectiveness of all the vaccines used in Mexico?
There are several vaccines that are used in Mexico. There are some that are from Russia. The Sputnik is one of the ones that are used. AstraZeneca has been used. Consica, one of the Chinese vaccines, are done. Effectiveness, I mean, you can find tables all over the place as to their effectiveness. However, considering that they don't have too many vaccines, what I tell people tell me, which one should be the best vaccine? I said, the best vaccine is the one that you have available to use. I mean, in the ideal world, if I could choose, I could continue to choose mRNA vaccines. I think that they, in the long run, they're going to be the best. But that's, again, my personal opinion.
Got it. Thank you. Lufimectin. So we call ivermectin a lufimectin as well. So lufimectin, as known as Jan Maslid, I will cry when I see him. So there is somebody who is crying right now. So Jan, thank you. Frankie says, are you hearing that more hospitals in the US are adopting your treatment protocols?
People are using the Math Plus protocol a little more than what they were a year ago. There is a slow acceptance to, for example, the use of methylprednisolone more than dexamethasone, but it's a very slow process. Again, it's extremely slow. Initially, people thought that we were crazy when we were giving steroids to patients with this pneumonia. And now we have actually shown that not only makes sense, is the way to go.
Got it. Thank you. Will Lovins says, if you were made to choose just one medicine for all early treatments, what would it be?
That's an easy one, Will. Ivermectin.
Got it. And please don't mind the next question. Dr. Varun is now pushing the vaccines. I thought the doctors at the FLCCC did not believe in the vaccines.
As I said earlier, and we discussed this earlier, it's not that we don't believe in the vaccines. We think that these are two things that need to be done complementary. And as I mentioned, if you have either you're going to have COVID or you're going to get COVID. So getting COVID, at least from a vaccine standpoint, is not a bad thing to do. Yes, some of these vaccines require a little more studying and things like that, but at the present time, we need to look at what is the best for humanity, the greater good. We have given about 2 billion vaccines around the world, and yes, you are correct. This is the greatest human experiment in the history of mankind. And yes, some people have gotten in trouble, but the vast majority of people have done well. So FLCC doesn't say do not vaccinate. We are not anti-vaxxers. With what we do say is, vaccination is going to take time, and it's going to take a long time. In the meanwhile, you can have a medication or a group of medications that can prevent you from getting COVID. And in some extent, even if you were to be dealing with one of these unusual variants, will even protect you. So that's what FLCC says. FLCC doesn't say, hey, vaccines don't work, throw them away. Some of us have a little more stronger thoughts than others, but what we want is something to be given to people that cannot be receiving vaccine easily, so that we buy them time.
Got it. Makes sense. Thank you very much. Pete Lincoln says, is there any way of knowing how much ivermectin is being prescribed in the US off-label?
Yes, actually, there is data. Dr. Marik recently sent me a graph, which I don't have at this time, but I can tell you that Texas is one of the states, particularly Houston, that has the highest peak of ivermectin sales. I wonder why.
Got it. So I think you may have something to do with that. So Alfred E. Newman says, and he is for President 2024, has the nasty letters he reported from the state of Texas in his interview with Ivory Hecker been resolved?
Not yet. We're working on that. It's it's a process. And again, when you do things different than others, people are going to come after you, whether it's your own colleagues, whether it's people that are uneducated on the science, but it's part of life.
And has he used Ciproheptadine at all for treatments?
I would say in about 95% of my hospitalized patients, I have them on Ciproheptadine.
Got it. So we still have a lot of questions. How is the time looking for you?
I have another 5 to 10 minutes.
Okay, so let's do this. On the YouTube side, the live side, we are live on Facebook and YouTube. A few questions, let's take them from here. So first question is Patricia Norikis says, is it not more of a chance to get COVID because if there is a virus on board because of recirculated air on a plane?
Yes, but again, planes have filtering systems. Planes have some exchange systems that can pretty much get rid of the virus. But the place where you're going to get the virus is going to be from the guy sitting next to you who's coughing. So that's why you both have to have the mask.
Got it. Dewey Robert says, do the vaccines settle in the ovaries and bone marrow?
Well, we know that that you can find antibodies in pretty much every organ in the body that has some circulation. For example, you will not find one in the cornea, but everybody else, everywhere else, you can find it.
Got it. Adina Sladek says, if a patient asks or demands to be treated with eye mask protocol, does that remove liability from the doctor?
Well, that's more of a legal question, and I will tell you, patients, at least, they demand, one of the things that I hear that they demand a lot is that they demand hydroxychloroquine. A lot of families, we have their patients in the hospital, they are not doing well, and they really demand it. So I don't think that that's a liability. One thing that you need to understand, and all the state boards need to understand as well, is that there is no standard of care for the treatment of COVID. What we're doing is we're trying to establish a standard of care, but there is no standard of care. So when somebody pushes you to do something, it's a doctor decision as to whether or not you're going to proceed.
Got it. Couple of more questions. Art Patron Forever says, hospital stopped Dr. Marik using ivermectin to treat COVID patients. Is mortality increased or decreased by hospital changed treatment protocol? If increased, how does hospital justify such a change?
I would say that that's a question that only Dr. Marik can answer, but I'll tell you that he really pushes for ivermectin, and he tries to do the best for his patients, and he's one of the best physicians I've ever met.
Got it.
And he's my friend, so I'm a little.
Of course. So Liza says, what Dr. Varun will consider a clinical turn on patients to call a COVID mutation? Sorry. So the question is, what Dr. Varun will consider a clinical turn on patients to call a COVID mutation?
Well, that's a good question, because I'm still trying to understand what the question is. But what would I consider a mutation? I would say when I have a presentation that differs from my standard presentation. And not only that my treatment strategy would not work in the same way that it does with others, not to mention, obviously, the genetic sequencing and stuff like that.
Got it. Last two questions. So first one, Grace says, what is the appropriate use of ivermectin for prevention of vaccine complications?
That's something that we're studying at the present time. I don't have a full answer, but I'll tell you, my patients, as I said, I try to have them to have both. And they continue to take ivermectin long-term without any major issues.
Thank you. And the last question, Luis Grande says, I read Lambda is in Texas. Do you have any info if this might outcompete Delta? Also, are there cases of fungal infection increased related to COVID outbreak?
Lambda has clearly gone up, and as you know, Lambda is quite prevalent in South America. Colombia and Peru tend to have a lot of Lambda. We have seen a couple of cases in Houston. However, the infectivity of Lambda is not as bad as the infectivity of Delta. Delta spreads like a wildfire. Delta spreads really bad, and that's why Delta supposedly originated in India. And look at what happened to India. I mean, it spread through a country of 1 billion people in no time. So I think that Delta is the one that we need to be concerned about. Lambda is there still gonna get us in trouble. And the second part of the question was
the fungus. Have you seen more fungal infections?
Yes, we have. We actually have seen quite a bit of fungus, a lot of aspergillus. I mean, we see a lot of aspergillus. We don't see as much mucor as has been reported in other places. A lot of aspergillus. And for those who like to use the tocilizumab, let me tell you, most of my patients that had fungus were also on tocilizumab.
Got it. So with this, thank you very much for being with us. I cannot imagine Dr. Paul Marik, Dr. Corey, you, Dr. Madhuri, all in one place thinking about how do you help a patient. I am sure that whatever comes out of that discussion is going to be very useful. And we are seeing that with the iMask Plus, iMath Plus, iRecover. So thank you very much for your time and for your insights.
It is my pleasure. Thank you for letting me participate with you. And I hope that those who have watched us go to the FLCCC.net website, look at our protocols. But we didn't just make up these things. We also have literature there so that it's true evidence-based medicine, so that you guys see everything that's out there on the subject. And again, thank you very much for inviting me. Thank you for your cat to allow us to do this. And I look forward to talking to you guys in the future.
Perfect. Thank you very much. And Cool Beans, thank you very much for your time as well. I would see you now on Monday. Bye-bye for now.